Inability to sleep. Infants experiencing now often have difficulty sleeping soundly and for adequate lengths of time, insomnia. Infants may display exaggerated wakefulness states. Crying. NAS infants are often inconsolable due to increased irritability. High-pitched, continuous crying may be displayed. Excessive crying and agitation are some of the initial signs of the syndrome. The Moro reflex is often hyperactive, and infants often display an over-exaggerated response upon stimulation. Increasing tremors. NAS infants often display tremors during times of increased stimulation, intense crying periods or fussiness, and or at rest, quiet and alert. Tremors may display themselves as jittery, fine, or coarse movements. Increased muscle tone. Interruption of the autonomic nervous system as a result of NAS could cause increased muscle tone, hypertonia in the infant. This is demonstrated when a range of motion is assessed and strong resistance to movement is palpated. Sweating. The NAS infants may display sweating due to interruption in the autonomic system. Sweating may be noted on the infant's forehead or upper lip. Increased body temperature is also common, but does not usually present greater than 102 degrees Fahrenheit. Increased respiratory rate. Tachypnea, respiratory rate greater than 60 breaths per minute, is often seen in NAS infants. Nasal flaring and stuffiness may also accompany increased respiratory rate. The increase in noradrenaline is thought to cause the stress response, which is also a result of the dysregulated autonomic system. Excessive sucking. Sucking difficulties may be present in NAS infants. Extreme irritability may lead to intense sucking attempts, but poor feeding may also be an issue. Infants often attempt vigorously to suck on their fists.
Thanks, Amy. Now we should review some of the differences that may affect the symptoms. Preterm infants born before 35 weeks of gestation are at lower risk of experiencing withdrawal signs and symptoms for NAS and NOW compared to full-term newborns. There are several factors that influence the lessened severity of NAS in preterm infants. Preterm infants often have experienced less exposure to substances used by the mother during pregnancy, leading to an overall lower accumulation of the substances as compared to full-term newborns, whose mothers use for the full pregnancy duration. Other factors decreasing the likelihood and severity of NAS in the preterm infant include younger gestational age is associated with decreased placental transmission of substances, lower morphine clearance as compared to full-term infants, underdeveloped kidneys and liver cause decreased excretion, less fatty tissue available for substances to accumulate in, and immature receptors which are not as sensitive to substances as those found in full-term infants. Earlier the gestational age of the infant, the less severe the symptoms of NAS are, and this makes the assessment of NAS particularly difficult in preterm infants. Here are some differences in symptoms exhibited in the preterm infant compared to the full-term infant. In a study of preterm, 33 to 36 weeks gestation, and full-term, 38 to 40 weeks, infants exposed prenatally to methadone and nicotine, symptoms were compared to full-term infants. The preterm scored less frequently for sleep disturbance, increased muscle tone, sweating, nasal stuffiness, and loose stools. In the same study, the preterm infants scored more frequently for hyperactive Moro reflex, tachypnea, and poor feeding. Respiratory distress diagnosis occurred in 20% of the preterm infants in the study. Due to prematurity of lungs and gastrointestinal systems, those caring for preterm newborns exposed prenatally to opiates should consider not scoring increased respiratory rate or feeding difficulty. Many preterms require 2 feedings due to immaturity. A scoring tool specific for preterm newborns may need to be developed.
Thanks, Rob. Now let's discuss prenatal exposure to stimulants such as cocaine or methamphetamine. An abstinence syndrome related to use of central nervous system stimulants, cocaine or methamphetamine, has not been clearly defined. However, when using scoring systems developed for opioid withdrawal, it has been shown that the neurobehavioral abnormalities such as irritability, hyperactivity, tremors, high-pitched cry, and excessive sucking occurs. This topic remains controversial. The NAS score will rarely go above 7 when the baby is solely exposed prenatally to stimulants. If there are elevated scores, this most likely indicates prenatal opiate exposure. Cocaine use in combination with heroin seems to exacerbate the opioid withdrawal. A review by Coker-Lakota, 2014, has also suggested that maternal use of cocaine and methadone may worsen withdrawal. Babies who have been exposed prenatally to buprenorphine compared to babies prenatally exposed to methadone have decreased chance of experiencing NOW. Lower doses of morphine has been required as well as less number of days on morphine. The hospital length of stay is less than those babies prenatally exposed to methadone. The signs and symptoms of NAS may be later with prenatal buprenorphine exposure than with prenatal methadone exposure. The majority have first symptoms at 72 hours of age. However, when the variable of maternal tobacco use is included, the dose, length of time on morphine, and hospital length of stay is increased based on the number of cigarettes smoked.
So let's look at how we can think of the overall severity and duration of withdrawal. The severity and duration of withdrawal is influenced by the level of dependency on the substance, along with the following factors. If the opioid is a full mu receptor agonist, such as heroin, oxycodone, hydrocodone, hydromorphone, or morphine, there will be a maximal effect of the drug for pain relief and euphoria. These agonists turn on the effect of the mu receptor sites. Buprenorphine is a partial agonist that exerts significant actions at the mu opioid receptor. Its maximal opioid effects are less than that of full agonists and reach a ceiling where higher doses do not result in increasing effect. Because as a partial agonist, higher doses of buprenorphine can be given with fewer adverse effects, e.g. respiratory depression, than are seen with higher doses of full agonist opioids. Past a certain point, dose increases of buprenorphine do not further increase. Partial mu receptor agonists, such as buprenorphine, known as Subutex, has less maximal effect than a full agonist. Here is an important consideration about symptom severity. Severity and duration of withdrawal is affected by the amount of tobacco mom consumed prenatally. Cigarette smoking in opioid-dependent women has been found to adversely affect NAS, including total amount of medication required to treat NAS and the length of treatment. Neonates exposed to tobacco prenatally are more excitable, have greater muscle tension, require more handling to be calmed, and show more signs of CNS stress, like abnormal sucking, excessive gas, gaze aversion. CNS functional abnormalities have also been related to deficits in self-regulation or the ability of an infant to be able to soothe themselves. The use of vaped nicotine, or electronic cigarettes must be assessed. Nicotine is an addictive substance. The amount of nicotine varies from cartridge to cartridge. Therefore, exposure to the fetus will impact the severity of NOW. Thanks, Amy. You may remember our earlier chart regarding the onset of symptoms for several drugs. Here are some other ranges for the onset of NAS symptoms. While the timing of onset of symptoms vary based on the drug properties and its half-life, selective serotonin reuptake inhibitors, tricyclic antidepressant and inhalant, prenatal exposure may result in symptoms of withdrawal between 24 and 48 hours of age. Symptoms of withdrawal from prenatal exposure to methamphetamines may present at 24 hours of age.